The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Welcome to Your Health, Your Choice. It's a pleasure to join you again Wednesday night. So we always try to remind you whether we are live or not. Well, we're live tonight, and it's the 27th of March. So when you see these programs replayed on a Thursday or Sunday evening, just remember you wouldn't be able to call in or WhatsApp your questions. Your Health, Your Choice. What are we about? We're about empowering you, the lay public, to make wise decisions about your health care. And of course, we know that there's so many medical programs, alternative programs out there, but we want to give you what we consider solid scientific evidence for your medical care. And today, well, as you know, my wife is usually with me, so I know many of you would prefer to see her face than mine, but I understand that. You're going to have to deal with me, and I have a very handsome gentleman with me. I'm very pleased to welcome Dr. Nijhawana.
Perfect.
Got that right?
Absolutely.
Neil, it's good to have you
Thank you very
on the
much.
program,
Thank you.
and thank you so much for accepting the invitation. I only met you yesterday
Yes.
at a conference you were speaking at, and you agreed to come onto the program. Now, Neil is going to tell us a little bit about himself, but he's of Trinidad. Well, you were born in Trinidad and left here.
No, I was actually born in London.
Oh, you were born in
I was
London?
born in London, but my mum's from Trinidad.
Right.
So came back here when I was one.
Right.
Grew up here. Went to school in South Fernando. Went to Presentation College.
Unfortunate, but that's okay.
You know, rivalries continue. Went to Pres and then left actually after my O levels.
Right.
And then did my A levels and then all my university training in the UK.
So Neil is a palliative care consultant, and I just want to bring up slide 1, just to give you a little bit of an idea of his background. He's a consultant in palliative care medicine, clinical lead for palliative medicine, Imperial College Healthcare NHS Trust, which from my knowledge is a very prominent healthcare trust in London. And well, you see the spectrum of his qualifications: BSc, a PhD, etc., etc., etc. So highly qualified, and it's an honor to have you on the program.
Thank you for having me.
Neil, yesterday you hosted a seminar on palliative care, and it's a specialty. It's an area in Trinidad that I think it's relatively new. Although we have heard about palliative care over the years. There are lots of myths about palliative care. So what I wanted to do today is talk a little bit, first of all, about how would you define, before we talk about the myths of palliative care, how would you define palliative care?
Palliative care is, as you say, a relatively new specialty. It's only actually had its accreditation as a medical specialty over the past 20 years in the UK, certainly. Palliative care is an approach to care. And it is very much an approach to care that is practiced by both doctors, nurses, and other healthcare professionals, specifically with the care of patients with progressive life-limiting illnesses. And that will cover the spectrum from anything from end-stage cancer to heart failure, end-stage renal failure, and so on.
Right. You had a very nice definition of palliative care, and it's slide 11. I just wanted to bring up slide 11, and I'm waiting on Josh to bring up that slide, but I liked how you made it very, very easy for us. So if you just take us through this definition.
So I think there are very many very wordy definitions that I certainly am aware of through my training. I was at an American Academy of Palliative Care conference a week and a half ago, and on one of the plenary sessions, this was the definition that they suggested. So palliative care is really the care that you would want if you or someone you loved was seriously unwell with a life-threatening illness.
So that's, I think, an amazing definition, because it puts yourself, as healthcare professionals, we are then putting ourselves in the place of the patient,
Absolutely.
the relatives, etc.
Yeah.
And I have to say, one of the common, I don't want to use the word complaints, but one of the things that we get fed back about is patients very often find that they're not treated and listened to. And it's something that, we're trying to, the younger doctors coming through, we're trying to train people to understand that listening skills are extremely important. Can I just ask you a question?
Yes.
I didn't tell you I was going to ask you this, but what drew you into palliative care?
Yeah, very good question. So I was very much a medic's medic. I was medical registrar for a while and enjoying both cardiology and gastroenterology. I didn't like the way medical training was going. It felt very 9 to 5. The vocational side of medicine wasn't there. You weren't allowed to spend that much time with your patients. And at the time, the job I was doing, we had a lot of patients who were having input from palliative care. When I was a very, very junior doctor, if we had patients who were dying, the consultants wouldn't see them.
Right.
They say, you're the junior doctor, the house officer can do the ward round. They simply wouldn't see them. And it irritated me slightly because we have that spectrum of development from neonates, babies, children's, all the specialties in medicine. They're all given huge amounts of attention and respect. Why? Because someone's at the end of life, should you treat them with any less attention and care? And in fact, when people are at the end of life, you need to see them more regularly because the changes that take place at the end of life happen very quickly.
Right.
So you need more attention to detail. That's why I got into palliative care.
Well, we were talking just before we started, the way we have been trained, most of us as doctors, is to cure people. And I think it's a really change in the paradigm of thinking that you're now going to deliver care to someone who's at the end of their life. And for many of us as doctors, we probably don't want to deal with that. And we even may think of it as failure.
Yeah.
Have you come across that?
That's very common.
Yes.
Even in the UK, it's a common sentiment. The medical students, junior doctors that I teach say, well, that's not what I came into medicine for.
Right.
I think things change, people mature, but what it really boils down to is the fact that, as you say, people come into medicine because they want to cure, they want to help.
Right.
You do have to realize that actually all biological beings have a finite end. We will all die at some point. What you have to do is deal with what you have in front of you. And sometimes the fact of the matter is, at some stage in the patient's life, they will die from one of their illnesses and you can't fix it, you can't repair it. That does not reflect badly on the patient or the doctor. But you're quite right, a lot of the angst about it is the doctors feeling that they can't deal with it. And what they really, really struggle with is the emotion that comes with somebody who's at the end of life from the patient and the relatives. And doctors find that hard to deal with.
Right. I guess coming to our local setting, it might be even more difficult. Because what I've found, now having been back for over 12 years and remembering my period of growing up here in Trinidad, death is something that, as a culture, we're often not very comfortable dealing with it.
Yeah.
So even more so within the medical field, our patients are coming into us and we are wanting to give them curative answers. But sometimes we have to say that there's no cure.
Correct.
And training people to do that is sometimes very difficult. Can you just paint a picture a little bit of your setting in the UK? And then we'll come locally and talk about what's happening here in Trinidad. Okay,
so I, as you said, I'm a palliative care consultant at Charing Cross Hospital, which is in central London. Our team is comprised of both doctors and nurses, all specially trained in palliative care. We have no patients directly under our care, but what we do is other teams refer to us. So we will have patients being referred to us with end-stage cancer, people who are on intensive care for multiple reasons and aren't getting better, are continuing to deteriorate, people who come into the accident and emergency department who are dying from a traumatic brain injury, for example. So we get exposed and we get asked to help with any variety of cases. And our role is to help manage symptoms, help psychological distress. And because patients very rarely come by themselves, they come with that support unit of family and carers. Part of the job is also to support them.
Now, we defined what palliative care is, but there's a lot of misunderstandings, misconceptions of palliative care. Slide 8 takes us through a few of these things. So Neil, you could probably just quickly take us through some of the things that palliative care is not.
Yeah, so a lot of these myths are things that I've experienced in my day-to-day practice. A lot of people think that palliative care is only for people who are very much at the end of their life and not having any treatment of any sort. A lot of people think it's only about pain relief and helping with vomiting. A lot of people still think that palliative care is only for people who have a cancer diagnosis. A lot of people think that only specialists can provide palliative care. Quite erroneously, a lot of people think that palliative care actually speeds up the dying process. And tied up with that, a lot of people automatically associate palliative care with the use of morphine and sedating drugs. Right. Sorry.
Yeah. So, you know, when I spoke to you at the start, I said, even in my thinking, I thought palliative care was more to do with patients who have had cancer and metastases and more pain control. So slide 9 talks, I think it begins to outline a little bit more about palliative care. Again, that's a WHO definition.
So it's palliative care, as I said before, is very much an approach to care, and what it does is actually takes a very holistic view and starts very much with relieving pain and other physical symptoms which are very distressing. The palliative care approach is very much about affirming life and regarding death or dying as a natural process. It's very clearly not about shortening life or hastening death. It's about making the most of whatever time you've got. But because people are more than just the person you see in front of them, people are more than just a diagnosis on legs. There's a psychological and a spiritual side to what gives people's lives meaning, and you've got to address that as well.
So we'll just come off that slide because I said to you before we started, I also I'm co-vocational, also a pastor. So when we talk about the spiritual dimension, of course, we're not talking about any particular religion, of course. No. But are doctors comfortable talking to patients about, even here in Trinidad, the psychological aspect is tough enough.
It is.
As a culture, we're not very good at talking about depression, and I think in the UK, people are a little bit more comfortable getting better. But that psychological and spiritual balance, how have you been able to get that that balance?
I tell you, so I'm very much a medic. I'm not a psychiatrist.
Right.
I sit down with patients either at home or in the hospital, wherever I happen to see them, and a lot of them assume I'm a psychologist or a psychiatrist. I'm not that clever. I think what makes a difference is being able to connect with people to people first. I often say, you know, person first, doctor second. If you can speak to people on a human level, it becomes very easy and people open up. And once you've developed that rapport, you know, we're in a very privileged position as doctors. What other vocation do you go up to a stranger and they tell you everything about your life? That doesn't change at the end of life or when people are seriously unwell. So if you are able to develop a rapport and speak to people, they open up really quickly. You've just got to give them a little bit of time. And so there's hearing what they're saying, but there's active listening, and just drawing the story out of them. Like the teachers at medical school, you listen to the patient, they'll give you the diagnosis.
Right. So having, you were trained in the UK, what drew you back a few years ago to come back to Trinidad to have some input into, and what did you find in terms of palliative care here in Trinidad?
So when I heard on the sort of Trinidadian medical grapevine that NCRHA, North Central Regional Health Authority, and the Palliative Care Society had come together in a project with a vision for an inpatient palliative care unit or a hospice. A mentor of mine who's a Trinidad-trained cardiologist, he mentioned, is this something you're interested in? I said, oh, absolutely. And so when I got here in 2013, NCRHA and the Palliative Care Society had done excellent work, had renovated a dilapidated ward or wing of Cora Hospital, and they've put together a beautiful 12-bedded inpatient unit. My job when I came back was to commission it get it up and running. And that's what we managed to do.
Right. So, Cora it's fully commissioned, and it's now being run by local doctors, nurses, etc. I'm going to come back to what's happening in other areas of Trinidad, because we know that there is palliative care being done in other areas. But slide 13 is a combination of palliative care, end-of-life care, and terminal care. And I just wondered, I'm just going to bring that up. And I know we're going to have to go to a break soon, but can you just take us through this particular slide?
Yeah, so I think the way to think about this is almost like an onion with layers. Palliative care and end-of-life care often get lumped together. The way to think about it is palliative care is the sort of care and the approach to care you give even at the onset of someone's diagnosis, for example, with stage 4 lung cancer or whatever. That's the phase at which the person's still having disease-modifying treatment or anti-cancer treatment. Then often once they get to the last year of life, that's often phrased at the end-of-life care period. And then terminal care is very much the last few days or weeks of life. So that's the difference. Palliative care encompasses all of that. So
yesterday we had a fantastic seminar. I had to leave a little bit early. You've done what the North Central has done. In the Southwest, we know that I only found out today that there is a clinic being run, an outpatient clinic. But in terms of what you did yesterday, you're now working with a group of people and a group that you're going to tell us about. What are your plans in terms of...
So I was asked to come back to Trinidad on this trip by a group called SMARA, which is a cancer support group set up by Mrs. Patricia Tikasing. And what this group has got together, what their vision is to try and have a palliative care unit in the south of Trinidad. So the vision at the moment, and I must say it's very much in the kernel stages, in the early stages of development, is a joint venture between SMARA and Victoria Nursing Home. Those two groups of people have come together, and they really do want to have a palliative care inpatient service for South Trinidad.
Okay, we're going to have to go to our first break. Thank you very much for joining us tonight. We are talking about palliative care. We're very privileged to have a UK-trained consultant, formerly from Trinidad, Neil, with us. And when we come back, we're going to continue our discussion. We're going to ask you, maybe in the second segment, to if you want to call in to ask questions about palliative care. Now, I know when I'm on this program, you ask about diabetes, but I'm asking you tonight that we stick to the issue of palliative care, and also you can WhatsApp your questions. The WhatsApp number will come up in a few minutes. So the number is 652-4855, 652-4855. We go to our first break, and we return to Your Health, Your Choice.
Looking for a safe place for the whole family? Well, now you found it. We are ACTN The Voice, your family-friendly station. Whether it's current affairs, kids and classic TV, sport and community features, Christian and music programming, plus so much more, ACTN is the station for you. Join us each day for programming that puts morals, values, and family first. We are ACTN The Voice, your family-friendly station.
In this time of challenges our nation is facing, an intervention from God is what we need. Do you need a breakthrough in your life, family, and business? Life Vision Ministry and the Trinidad and Tobago Christian Churches present a National Healing Crusade 2019 with returning evangelist P.S. Rambabu from India.
When you go through Moses, you go to God. When you go through Jesus, you meet the Father.
Join us on Thursday, the 11th of April to Saturday, 13th of April 2019 at North Central and South Trinidad.
Enough you worshipped Him as God. It's time you know Him as your Father.
Come experience the power of God as we impact our nation to reach its destiny through the miraculous power of Jesus Christ.
Sunday at 2 p.m. on ACTN The Voice. We'll be taking you on a journey down memory lane with our Sunday classics. Relive the moments. Bonanza at 2 p.m. Little House on the Prairie at 3 p.m. Gilligan's Island at 4 p.m. Family Matters at 4:30 p.m. Hogan's Heroes at 5 p.m. The Jeffersons at 5:30 p.m. This is Sunday Classics on ACTN The Voice.
Welcome back to Your Health, Your Choice. It's the 27th of March, Wednesday night, and we are live tonight. Just to remind you, when this program replays on a Thursday and a Sunday night, you can't obviously call in because it's going to be recorded. But tonight, in a few minutes' time, you can call in your questions on 652-4855, 652-4855, and a WhatsApp number will come up as well, so you can WhatsApp your questions. And we are asking you tonight to try and stick to the topic we're talking about, which is palliative care. So we are privileged to have Dr. Nijhawana, right, with us, and born in the UK, came back to Trinidad at one year old, did your primary, secondary school education, and then went back to the UK, and you've been living and you were trained in palliative care. I really want to just congratulate you again for taking, I think it was 2 years, you said you came back in 2013 to set up and commission the Cora unit. And I think that was a milestone. Now, there are some other hospice movements in Port of Spain. Can you tell us a little bit about that?
So certainly, I think the first sort of palliative care or hospice movement or organization that we had in Trinidad was the Living Waters Society. And they have got a hospice which most recently has been run by Dr. Richard Clark. And they're in Port of Spain. We've also benefited from Vita's House Hospice, which is on the same grounds as the St. James Infirmary. And while Vita's House focuses purely on a hospice for patients who've got cancer, the Living Waters Hospice accepts all diagnoses.
Right. So I just want to, before I go on to the other diagnoses, which I think we really need to talk about, because as I said, the traditional kind of idea is that palliative care was more based on cancer treatment. In Tobago, there's some palliative care being done as well.
So on the oncology unit in Tobago, there is a palliative care trained nurse, Karen Frank, who effectively runs a palliative care service on the wards in Tobago. Right.
Now, palliative care is a specialty in its own right, and I know there are several family doctors who have been exposed to doing palliative care. Having done family medicine in the UK, we did minimal amount, but there are people now who are being exposed to more and more training. Are you coordinating some of that from the UK, or they are accessing the training themselves?
No, I think there are a number of sort of UK trained GPs or family medicine doctors who do palliative care in Trinidad, and they've accessed that training themselves. They are in the position of providing training to other doctors here.
Right. But just on that point, in terms of, for the future, doctors wanting to specialize in palliative care, at the present time, that cannot be done locally.
No, not formally. I think if you want to become a consultant, for example, in palliative medicine, there is no pathway for that in Trinidad. You'd either need to go to the UK, Canada, or the US, and then come back.
Is that a common phenomena in labeled as a third world country? But do you find that in many other areas of the world, palliative care is kind of lower down on the ladder of priorities?
It is. It is changing. Things are absolutely changing. In many parts of the world where there are resources even more scarce than Trinidad, and we mustn't beat ourselves up too much. Trinidad is actually quite well catered for in terms of medical infrastructure, including palliative care. If you compare like for like with other Caribbean countries, But actually, even in parts of the world like India, Uganda, where there isn't really postgraduate medical training of any sort, there is a huge groundswell movement of non-medically trained persons, volunteers, providing palliative care to patients in the community.
Right. So we talked about the traditional concept of palliative care being more thought of as a cancer a specialty in that area.
Yes.
What are some of the other kinds of patients you see?
So because palliative care deals with any patient with any life-limiting illness, as you say, cancer is the main thing. Traditionally, that's where palliative care has been affiliated. But actually, we see any patient with any progressive life-limiting illness, and that could be somebody who's got end-stage kidney failure and has decided not to have any more dialysis or isn't well enough to have more dialysis. It would include patients with end-stage cancer of any sort who aren't fit enough for any more treatment. It would include patients with end-stage dementia, like end-stage Alzheimer's. Literally anything, any medical condition which is actively shortening your life and which is irreversible, i.e. we can't cure it, we give palliative care to.
And this is very much a multidisciplinary team approach. And I have slide 17, which gives us some of the members of the team. And, you know, this whole concept of a multidisciplinary team approach to care is one. So we have some of the members of the team. You can probably just take us through that.
So this would be your gold standard multidisciplinary team, you know, comprising of lots of different healthcare professionals, not just doctors, but nurses, healthcare assistants, social workers, chaplains, counselors, psychologists, if you're really fortunate, complementary therapists and volunteers. If you think about the complexity of care when patients come into hospital, not just palliative care, there are many, many, many needs. Those needs aren't only able to be met by doctors and nurses. So the more skilled and varied your skill set in terms of your team, the more likely you are to meet those needs.
Right. The problem, we can just come off that slide. You know, when we talk about palliative care, the whole idea of death is something that we have to come to terms with. And we were talking again just before the program that as physicians, we are trained to offer a cure for our patients. So when patients develop a terminal illness, sometimes even as doctors, we think of it as a failure on our part. And you gave me an example that some of the consultants you worked under in the UK even had that kind of approach. How, as a culture, how do you think, I mean, how can we change even as doctors, healthcare professionals? We looked at the multidisciplinary team approach. I mean, we are stretched, as you know, in our healthcare resources on the government service. The movement you are trying to put together in the Southwest region, unlike North Central, that was supported by the North Central health authorities. Hopefully the Southwest will come on board, and you know, if there's an outpatient clinic already in place, I mean, maybe the Southwest region will see the need to support this care. But right now, it is a voluntary organization that's driving this.
Yes.
But in terms of talking to patients about death, you made a comment yesterday that, and I see this very much in Trinidad, patients and the relatives often do not want us to tell their mother or grandmother that they have a terminal illness.
That's true.
How do you deal with that? A relative is sitting behind and saying kind of no. And how do you deal with that scenario?
So I think the first thing to say is that's really common wherever you are in the world. Certainly in the UK, we get this extremely commonly. And the way I tend to deal with it is I tend to say to the relatives, and I try and get the entire family group together when we have a consultation. I said, I do need to be open and honest with you. I won't collude. I won't keep secrets. Now, clearly, if a patient is extremely unwell and is unable to partake in a fairly detailed conversation, then you're not going to step over that line and intentionally distress them. But that aside, most people on the whole are quite sensible. I think people are very, very hard on themselves when they're unwell. But on the whole, people are very, very sensible, and most people are aware of what's happening to themselves. And it's very, very common, as soon as the relatives leave, the patients say to me, "Doc, I know what's happening.
Right.
How much time have I got?"
So is it the relatives are more uncomfortable talking about death?
Yeah.
Rather than the patient very often? Because you're right, a lot of our patients know when they're terminally ill.
Yeah.
But relatives often find that diagnosis very difficult. As you know, I shared with you that, and I've been very public. My wife says I'm too public with my illnesses, but I was diagnosed with colon cancer last year, and the Smaro group was very much involved. I was at the unit there. Fortunately, there was no spread of the cancer, so I'm cancer-free at this point. But I was very not comfortable with the diagnosis, but I came to terms with it. But a lot of my relatives, I guess, they went through a very traumatic time during that period of hearing the diagnosis, etc.
I mean, there is a real stigma associated with cancer, the C word.
Yes.
A part of the thing, and it comes from a real human perspective, people want to protect each other. So the relatives want to protect the patient, don't want to give them any bad news. The patient wants to protect the children usually. I don't want to put any pressure on them, and everyone's trying to protect each other. You end up walking around on eggshells and not dealing with the elephant in the corner.
Yes.
The problem with doing that is that at some point, somebody makes a mistake and something slips out.
Yes.
And then you end up with a huge amount of distress. And I have to say the answer to all of this is, as always, communication. Very, very clear, open and honest communication. So by that I mean I will sit down with the patients, with their relatives, whoever that big support group is for that patient, and explain to them, this is the situation. You've got, if it's cancer, a very advanced cancer. There is no more treatment for that cancer available, if that's the situation, or if they're not well enough for any more treatment, or if they're deteriorating in spite of that treatment. And what we need to say to them is actually, you know what, as doctors, we have a duty of care to be open and honest with you. And sometimes the interventions or the treatments that we offer end up doing more harm than good. When that is the situation you're focused with, your duty of care is to explain that to your patient and their family. It's not about abandonment. It's not about giving up. It's about doing the right thing.
And you're absolutely right. You know, I think very often patients are offered treatments and they're not very clear about what the end point of this is. So be it chemotherapy, if there's already extensive spread of the cancer, metastases is the word that we use, or people with end-stage COPD, chronic airway pulmonary obstruction, people in cardiac failure. The mortality associated with cardiac failure is often as high as some types of cancers. And so we have patients coming in with repeated admissions to hospital. And you made the point yesterday that, you know, with each admission, there are shorter intervals, and patients are coming in and sometimes they're not understanding that the treatments we're giving, just take heart failure for an example, it's really palliative.
It is. I mean, if you think about heart failure, unless you're going to get a transplant, the heart failure is going to shorten your life. There's no way around that. And what generally tends to happen is patients come in very out of breath, very, very swollen, lots of fluid. They get admitted to hospital, they get put on oxygen, they get given diuretics, the fluid comes off, and then they go home again, they feel better. And that happens fairly frequently. What you have to look at is every time that episode of heart failure happens and they need admission to hospital, yes, they get better, but every time they get better, their baseline level of function drops. And so there's a progressive deterioration. And if the episodes of admission to hospital start getting closer and closer together, that's a real marker that the body is struggling and people are deteriorating very quickly.
I think that's one, and by the way, the numbers for the questions are up now, 6524855, and the WhatsApp number is 3600105. Now, as I'm saying to you tonight, if you ask questions outside of palliative care, I may have to refuse your questions tonight because we really want to stick to this area of palliative care. So one of the issues coming out of that is the whole thing about doctor shopping. Because if patients don't understand that the doctor you're seeing, they're trying the best to give you a good quality of life, and now we're coming to the whole concept of quality of life, which I want you to just to elucidate on a little bit. Then they begin to go from doctor to doctor. They may go to alternative practitioners who, and I'm not just saying alternative practitioners do this, but sometimes healthcare professionals give hope of healing or complete remission. So in my area of specialty, diabetes, patients often coming to me and say, well, do you have a cure for diabetes? And, you know, we have to explain this whole concept of chronic disease management, etc. But in terms of quality of life, so there are two areas I wanted to talk about. First, quality of life and the whole holistic assessment of a patient. So how would you define quality of life?
Quality of life really is something very personal and subjective. What someone finds acceptable, the person in the next bed or the next room may find unacceptable. It's perhaps best illustrated by an example. So I often have conversations with patients, and again, we're using cancer a lot because that forms a lot of the patients I see, but often I see a lot of patients with terminal cancer, end-stage cancer. They're extremely frail. They're in hospital. They're unfit for any more treatment. But they're not entirely accepting of that. They say, well, maybe if I have a little bit more treatment. And I often have to say to them, I need to have a very blunt conversation with you, a very open conversation, because what you need to understand, what's in the balance, is at the moment, as you're really frail, very unwell, unable to have any more cancer treatment, we can make plans, look after you, make sure you're pain-free, well cared for, and get you home if that's what you want. The flip side to that is staying in hospital, having more treatments, having more antibiotics, more interventions. When people are that frail and that unwell, the risk is the longer you stay in hospital, the lower the chances of actually getting you home. And when you talk to people at the end of life and you ask them what they want, the vast majority of people will say to you, Doc, if I have a chance, I'd like to die in my bed at home. And so what you actually end up losing is the chance to get home. The longer you stay in hospital, the more doctors are going to do things to you. Because as you say, we're trained to do that.
Intervention.
Which is why it's much easier for doctors to prescribe than to take medicines away.
I think we are right. We have a question here. Please ask Neil to go over how to refer to the public palliative clinic. So this might be somebody from one of the groups, the smaller groups. So they're asking me to ask you, Neil, how do patients in Trinidad get referred to some of these units like Cora, etc.?
Okay, so I think did we have a slide with the contact details for Cora?
Okay, that's on the other slide set, which I'll try and,
Okay, so shall I just run through those?
Yes.
So there are a number of different ways. One is the palliative care unit at Cora. If you call Cora Hospital and ask to be put through to the palliative care unit, the team there will take a referral or at least talk you through the process.
And can that referral come from anywhere in Trinidad, or is it just North?
No, we take referrals from the entire country. We've actually had patients come, Trinidad patients from abroad, come back home, and we've accepted them to the unit. Generally, we would like a doctor to do the referral, but if there isn't a doctor to do the referral, we do get people to come to clinic. So that's one way to do it. If you're having treatment at one of the oncology centers, usually it's St. James, the doctors there are able to refer to Vitas House Hospice.
Is Vitas House Hospice a private organization, or is it funded by the Northwest? No.
So Vitas House is part and affiliated, apologies if I got this wrong, but they are affiliated with the Cancer Society of Trinidad and Tobago. So Dr. Jackie Sabga is the main clinician heading that up, which is why they exclusively deal with patients who've got diagnoses of cancer.
So Vitas House deals
purely with cancer. Right.
So someone brought this up. Cora Palliative Care Unit. Thanks, Josh. The numbers are 662-4053. There's also a fax number there, and there's a referral form. So thanks a lot, Josh. If you need more information about that, you can call our office number 482-4269, and my personal assistant will give you the appropriate numbers, and we'll because there's a lot of information we want to cover tonight, but the referral to Cora is fairly well defined.
It is.
And the numbers are there. So thanks for that question, and you can keep on WhatsApping your questions or calling in. We're going to go to our second break, and then we come into our last segment. So time is going very quickly, and we still have to talk about pain management, which is one of the areas I know people would be interested in. So we're going to go to our second break, and then we come back to Your Health, Your Choice.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. ACTN The Voice, your family-friendly station.
In this time of challenges our nation is facing, an intervention from God is what we need. Do you need a breakthrough in your life, family, and business? Life Vision Ministry and the Trinidad and Tobago Christian Churches present a National Healing Crusade 2019 with returning evangelist P.S. Rambabu from India.
When you go through Moses, you go to God. When you go through Jesus, you meet the Father.
Join us on Thursday, the 11th of April to Saturday, 13th of April 2019 as North, Central, and South Trinidad.
Enough you worshipped Him as God. It's time you know Him as your Father.
Come experience the power of God as we impact our nation to reach its destiny through the miraculous power of Jesus Christ.
ACTN The Voice, your family-friendly station.
Welcome back to Your Health, Your Choice. We're live tonight. It's Wednesday, the 27th of March. Again, you can call in. We have only about 15 more minutes, or you can WhatsApp your questions. We have a few questions coming in. I know palliative care is something that we have actually not covered before on this program. So I'm privileged, honored to have you with us, Neil, UK trained consultant, Trinidad born, well, UK born, but grew up in Trinidad and then migrated back to the UK. One of the questions here before, I wanted to end up the program talking a little bit about symptom control. A question here, what about home carers, usually family members who need to be there 24/7? Is there support for them?
So it's a very good question. At the moment, there isn't a formalized, widespread, sort of Trinidad-wide network of communities carers. Generally, I can speak for Cora because that's where I've got most experience. Generally, when we get patients to come to clinic and we see them, we get the family members to come as well, and we spend a lot of time explaining the ins and outs of care. We can often point people in the right direction so they can access private care. But in terms of a publicly accessible community help, that doesn't exist at the moment.
Neil, I have to say I'm excited about what I'm hearing about Cora. I'd heard a little bit about the process that has been started, but I mean, it's really a model that other regional health authorities can really look at and seek to do. We don't have to recreate the wheel.
No, absolutely.
We can duplicate, and someone with your expertise having set that up, we can then spread that to other areas in Trinidad, which is what we were trying to do with diabetes. Let's just say that. We talked about Vita's House, we talked about Living Waters, and then there's Cora, and then we think there's still a clinic at San Fernando Hospital, an outpatient clinic. In Tobago, there's something happening. Yeah. Forgive us if there are other areas where palliative care is going on. We know a lot of family doctors, you do a bit of palliative care, but we are trying to talk about formalizing this whole process. So I'm going to bring up slide 26, which talks a little bit about symptom control, because I guess a lot of patients and their relatives are concerned about this. So some of the symptoms associated with end-of-life illnesses. I'm going to bring up slide 26. Neil, can you take us through this?
So I've kept the slide fairly short, and pretty much what it says is that the main 4 symptoms that we tend to spend a lot of our time dealing with are pain, shortness of breath, nausea and vomiting, and agitation.
Right. So just come off that, and let's maybe we're going to spend most of our time on pain, because I mean, I can tell you, Neil, I see some of my diabetic patients with extremely painful diabetic neuropathy.
Yeah.
And we try to get our heads around it. These are patients who sometimes their diabetes is well controlled. There's no rhyme or reason to it, and we throw different drugs at them. And the common hesitation on the part of patients is not wanting to be on too many medications.
Yeah.
So what is your approach to, I know this is a broad question, to pain control?
Okay. So pain is one of the most difficult symptoms we face. The thing about pain is it's very subjective.
Right.
And the way you know it's subjective is people talk about pain thresholds and what they can deal with.
Yeah.
Somebody may deal with quite severe pain. The other person may find that quite trivial. So pain is what the patient says it is. The way I tend to deal with pain is, while patients may not describe their symptoms as being pain, any sensation which is unpleasant, uncomfortable, debilitating, and getting in the way of your day-to-day function is pain.
Right.
And the point is, you don't need to suffer, because actually, if pain persists, it becomes chronic. Chronic pain is one of the most difficult things to treat in medicine. And chronic pain is associated with depression, low mood, suicide attempts. So pain is actually not a trivial thing. It's quite debilitating.
Can I just say this to you? I have a patient with extremely painful diabetic neuropathy, and he's tried to commit suicide on 2 occasions recently, and that blows me away.
Yeah.
I know he suffers with depression, but he's actually tried to commit suicide.
Yeah.
And you're right, pain can drive people to drastic actions.
It can. It's pretty severe, and the problem is, I see this all the time, even in the UK, colleagues will say to me, well, he doesn't look as if he's in pain. With respect, we can't know what the patient is feeling. Pain is a very personal experience. The only way to really get on top of someone's pain is to actually spend time sitting down with them and asking them about their pain in detail. And what that means is actually taking a very detailed assessment of their pain.
Right. You asked us a question yesterday, and I got it wrong. What causes pain?
Yes.
And my response to you was it's the way people perceive pain. But you made a very important point about how people experience pain. And you just want to go through that again, where the tumor was located. You mentioned that.
Yeah. So pain. I think the other thing to say is when people say that the pain's in your mind, that's actually what pain is. We perceive pain in our mind. The process may be painful somewhere else, but you actually perceive it in your mind. So to say to somebody in a very derogatory way that it's all in your mind is really unhelpful. What causes pain? I mean, we're talking a lot about cancer because it's the easiest thing to relate to. People get pain because the tumor is pressing on something, or it's in a particular part of the body. So example, if you've got prostate cancer, and prostate cancer has a tendency to spread to the bones, if you've got pressure on those bones, if those bones are broken, if the bones have broken and are pressing on the spinal cord, you're going to get intense and severe back pain. If you've got tumor in the lungs, it may cause a degree of breathlessness. If the tumor is on the surface of the lung, very close to the skin, you'll get very localized pain, which is worse on breathing in. So what dictates whether you get pain from a cancer is the location of the tumor.
Right. So we have this kind of culture of people thinking, well, I'm going to get addicted to painkillers.
Yes.
And we only have about 8 more minutes. So I know you showed us a kind of pain ladder, analgesic ladder, pain relief. But this whole idea of, people being, having a terminal illness and these concerns that relatives or patients may have about becoming addicted.
Yeah.
What is your response to that?
So I deal with it. I never belittle it because it's something that transcends all cultures. Every culture, the patient that I've dealt with has brought this up as a concern. I've been doing palliative care for coming up to 9 years now.
Right.
I have never seen one of our patients get addicted. It doesn't happen.
Right.
Morphine, which is what everyone get worried about, morphine is just another drug. It is a part of a family of strong painkillers called opioids, and it's just another drug in the armory. My approach to pain is actually we will use whatever we need to relieve that patient's suffering. That doesn't mean throwing huge doses at them. It means using very small, individualized doses and gradually increasing it until the patient is either pain-free or their pain is at a level that they can function with.
So, when we talk about morphine, immediately, even as doctors, we get a little bit hesitant. I myself am. And, you talked about the simpler painkillers like paracetamol. And I've actually, after my operation, I was given IV paracetamol to try and weed me off the morphine, which was great. And I'm certainly one of those who didn't want to be in pain. So I shouldn't say I enjoyed the morphine, but it was very, very important to have good pain. And I have to really commend the doctors. I was on the nurses at Southern Medical that the treatment was excellent. But we're limited a little bit here in Trinidad. We don't have all that you have in the UK and the US.
No. So, for example, we have different preparations of morphine.
Right.
We have immediate release liquid morphine, or Oromorph as it's called.
Do we have the subcutaneous infusion?
So we've got oral morphine, which is either the liquid Oromorph or long-acting morphine tablets, or MST.
Yeah.
But we've also got morphine injection, and that morphine injection can be given intravenously or subcutaneously.
Right.
We do have codeine preparations. As you said, we've got all the simple analgesics, but I have to say, despite the relative shortage, in terms of availability or range of strong painkillers we have, morphine's an incredibly effective drug.
Right.
Most pains, more than 95% of pains, will respond to some degree to morphine. I very rarely see patients who are truly allergic to morphine. A lot of people are scared about morphine, and in Cora, what we used to do would give them a little dose of liquid morphine, and by little I mean 2.5 milligrams, a tiny dose. Give them 20-30 minutes so they can see and feel the effect and realize that just because they've had a dose of morphine, they're not just going to fall over and fall asleep.
And of course, people can have morphine orally at home.
Absolutely.
What about the subcutaneous? I know it's done obviously in patient, but in terms of patients in there at home, I know that's done in the UK, am I right?
It is done in the UK, but again, even in the UK, we tend not to rely on relatives to do that. We'd rather not burden relatives with trying to give an injection to some loved one who's in pain. You lose objectivity. So we rely on our network of district nurses to do that. But certainly, I have to, and other colleagues in the community here have trained relatives to administer injections. If there's a doctor or a nurse in the family, you can train them to give it.
Right. Okay. So, I mean, although we are limited, we do have several options to look at, and there was a referral form that, because we're sort of winding up, so I just want to use Cora as the point of reference for this particular purpose in terms of the referral pathway. That referral form, is it available widely, or do you have to access it at Cora?
Yeah, so if you call the number, Cora, the guys at Cora can actually either email or fax it to you.
Right, okay. So the numbers did come up, and if you need those numbers again, you can ring on 482-4269, and we'll try and get those numbers to you as I had them on my slide set. Neil, as we kind of summarize, we've talked about what's happening in other areas in Trinidad, but we come back to the southwest area and the project with SMARA and Victoria Nursing Home. It's in the relatively early stages. What's your kind of vision and hope of how this will evolve?
I mean, there is very clearly a need. When we were at Cora, I saw numerous patients being transported up to Cora in the back of a pickup truck.
Right.
There's a huge amount of need, and it's a long way for them to go. I suppose the vision really is to have a version of Cora down in South.
Yes.
That's what we need. We need an inpatient unit.
How many beds does Cora?
Cora has 12 beds.
12 beds, right.
Yeah. So we what we need is a facility that allows us to have inpatients and run clinics as well.
Right. And then you have people doing home visits.
I think that would be the...
Thanks, Josh, for bringing that back up. So those are the numbers again for Cora. And so we're just giving that as a basis tonight, the point of contact. And as other things are set up, of course, other telephone numbers. And this is the staffing at the Cora Hospital. Thanks, Josh. We didn't get time. So there are 10 RNs, 9 care assistants, ENAs, and then there are 4 doctors. So there are actually 4 doctors at the unit.
Yeah.
And this is a photo of the Cora Palliative Care unit. Really beautiful setting. So Neil, I'm so grateful that you have taken the time. I know it's you're only here for about a week, and you're going back to sunny UK. No, I'm being wicked. As I said, my son lives in the UK, so we often compare the temperatures we have here.
It's no comparison.
It's the one thing I miss. I miss some things about the UK, but not the temperature. So I really want to congratulate you on the work that you have done in commissioning Cora, and I know you're doing some further training there this weekend. And my hope, being based in the Southwest and having come to the seminar yesterday, that I want to congratulate Pat and the entire team. I know several of them will be looking on tonight. We really want to encourage you guys to continue this process. Any closing remarks? We just have about 1 minute.
I think palliative care is an approach which is essential. I think we tend to judge countries by the way we look after our very ill patients, and we have a lot of work to do. But equally, we shouldn't beat ourselves up. There are a lot of people in Trinidad at the moment, even without me, who are doing really, really good quality palliative care. But we need to make it more accessible for the wider population.
Thank you very much, Neil. So tonight we have talked about palliative care. It's a first for us on this program, and hopefully the next time Neil is here with us in Trinidad, we'll be able to have him back on, and maybe 1 or 2 of the other doctors and nurses who and supporters of the Sparrow Group. As I close off tonight, I want to remind you, if you have any questions, you can ring us or WhatsApp us on 482-4269. Or that number is the number we usually give for my office. I will take any questions you have or inquiries and pass it on to the Sparrow Group or Cora if necessary. So 482-4269. You can WhatsApp or call us for more information. As we close off tonight on Your Health, Your Choice, as you often know, I put on my pastoral hat and I give you a little spiritual thought for the week. On Sunday, I shared with our church on being bold. Now, when I mention that word, very often we think about being bold in terms of the Trini context. So being outspoken, telling people like it is. I often joke with people that Trinis, we love to give people a piece of our mind. But if you give too many people a piece of your mind, you have nothing left for yourself and for God. So you just have to be careful about that. But what do I mean by being bold? I want to challenge you to be bold in your integrity. Integrity talks about being whole, being the same on the inside as you are on the outside. No duplicity, being transparent, being authentic. So when I talk about being bold, and I challenged our church on Sunday morning, that they would be bold in the way we treat other people. The refugees who are coming to us from Venezuela, can we be bold to show compassion, care, and love for those who are in need? Can we be bold enough to show people on our workplace that we are honest in the way we deal with our colleagues, as well as, for me, my patients and relatives who come in? So be bold with truth, be bold with integrity, be bold with authenticity. I want to thank you very much for joining us on Your Health, Your Choice. The number to call if you have queries is 482-4269. This program will be shown again on Thursday at 1 p.m. and Sunday night at 6:30 p.m. We are also going to be placing it on Facebook, so look out for that, those of you who follow us on Facebook. Thank you once again for joining us on Your Health, Your Choice.